Now we would like to hear Ana Paula Fernandes and Carlos Sorgi, and they're going to talk about the plural study. Good morning, everyone. Can you hear me? Okay, great. Thanks for having me. My name is Ana Paula Moraes Fernandes. I'm at the University of São Paulo, and we're conducting the plural study funded by the university, and that is talking about inflammatory markers for HIV, AIDS, and COVID, including studies of the use of self-tests of antigens for SARS-CoV-2 for sex workers and healthcare professionals. Carlos Sorge is present at the event, and he will present our study, and then I will follow up on the presentation. Thank you very much for having us. It's great to be here, and Ana Paula, thank you for your kind introduction. Ana Paula and I are professors at the University of São Paulo in Ribeirão Preto, and we are scientific coordinators of this plural study. So now I'm going to show you a little bit of what we've been doing regarding this idea of decentralization of self-testing and how we are going to apply that in clinical research. So the plural study is recent. It was conducted in collaboration with other institutions, like the Adolf Lutz Institute, the CRT in São Paulo, the Barong NGO with large experience in serving vulnerable people and in situations of sex working and also in homeless people, and GermSure, which is working with us regarding tests for COVID-19. To give you a little bit of context, we had already been working with COVID-19 and studying the biomarkers of COVID-19 in cis populations. So we already had some important aspects that were discovered in the last year, especially regarding the pathology and how it was interfering in more severe cases of illness. So we knew that after infection through airways, the virus was located in the lungs, and there an inflammatory process started. This is regular at the beginning for a viral infection, but then the inflammation was much severe. So that had to do with the immune response of the host, of the person infected, and that would lead to a cascade, a cytokine storm. And we also found out that there were other mediators involved in this cascade. Besides the inflammatory cascade happening in the lungs and then was disseminated through other organs, that led to microthrombosis episodes and the leakage of fluids in the lung, and that would lead to a framework of acute respiratory inflammation, which is typical of patients in the ICU. So this is a demonstration of the inflammatory process. This is a review that our group published. And there you can see the filtration of, you can see all these cells and their roles. You have inflammation of vases, the cellular death and then you see a higher amount of dumps that can cause inflammation. So this is a very complex process regarding the immune system, and it's important to study the role of each and every one of them. So what we know from the clinical side is that we have some biomarkers that are classical that have been seen in most severe cases of COVID-19, like D-dimer. The increase of D-dimer was related to the coagulation problem, especially coagulation in the alveoli. Inflammatory cytokines were increased, the increase of neutrophils, and the decrease of lymphocytes. So that had to do with the immune response. And all these biomarkers together could show if the person was evolving towards a more severe case, or if that therapy implemented was being ineffective. Afterwards, we found out that there were other sub-biomarkers which were also important and regarding the medical decisions, and these markers could be immunological or metabolic. So what we have in COVID-19 progression, especially in the first wave, where we did not have variants, is that we had a stair of evolution, and not all patients did die. The mortality rate compared to other viral infections is still low, around 2%. The problem is regarding the infections. There's a high number of infections, but around 50% of people had no symptoms. And when we divided population between symptoms, between mild, critical, and wild. So why did we have this large spectrum? Because we had people with symptoms and people who were actually dying. So what was the difference between these people? And what were the comorbidities, or what were the reasons that were causing this severeness? So with the first wave, we had an idea, and then the second wave as well. This is a study conducted with Brazilian population. So age was an important factor. In the first wave, we had more elderly people being affected with severe illness, and then we had other comorbidities related, such as diabetes or hepatic comorbidities, cardiovascular comorbidities, neurological and respiratory comorbidities as well, aside from immunosuppression. So all of those comorbidities combined with risk factors like age, and then the male gender, that was also a risk factor, that really led to the large number of deaths in part of the population infected with COVID-19. So regarding this background that we have been studying for over a year, our main question was, how do co-infections collaborate with this process of COVID-19, especially STIs, and how, since the male gender was a risk factor because of a mechanism dependent on testosterone, and we are about to publish another study on that, So how did transsexual people who were actually marginalized from studies, so to speak, so people who were doing hormone replacement, how are they inserted within the risk factors? So the idea was to study co-infections of COVID-19 and STIs and consider the hormone replacement therapy on trans people. That is how the plural study was born. So our main goals, considering this background of co-infections, was to analyze the usability of rapid antigen tests, as well as self-tests. And in our partnership with GermSure, we created the self-tests for COVID-19. Also analyze sex workers, trans people, and entertainment workers and their vulnerability of COVID-19 and their exposure regarding their working places, and also determine the immunological response of people who had COVID-19 and STIs. And with that, we would determine metabolic biomarkers, describe the immune response on those individuals, and so be able to predict or talk about the outcomes and maybe treatments or even the failure of treatments.
In total, our project reached 1,500 people between patients and volunteers, and the project will be conducted in people's workplaces. We'll pick them up in their workplace and conduct a rapid test for COVID-19, HIV, HCV, HBC, and syphilis. And once individuals are tested positive, they will be divided into 8 groups, 4 initial groups, which are for cis individuals, and 4 groups for trans people. And the molecular studies that will assess the metabolic and the immunologic response will be developed in our lab inside the University of São Paulo based on the positive results of the tests and the different groups. But before looking at the result of the tests, we do a social study to assess the usability of the tests, the acceptance of such tests, with a social demographic study with all patients. And for those who test positive, we will also assess their peers and by donating tests so they can be tested at home. So we have established clinical protocols in our group, and they look at different important aspects regarding health and behavior of such individuals, and also research protocols with specific targets, depending, of course, on the molecular research that we conduct. So that includes the gene transmission, polymorphisms for some important genes as well, genes that are associated to a more effective immune response, and the biomarkers that are present in the plasma. So with this concept of decentralizing and using rapid tests, basically this project is only possible because of rapid tests. Otherwise, we wouldn't have access to these population groups, or we wouldn't be able to determine which individuals would be infected with COVID-19 or other STIs. So our protocol takes place on the street. The Barongi group has a lot of experience in approaching these individuals, sex workers and workers of night entertainment. And Barong has been conducting testing work in the work environment, a testing initiative in the work environment for a long place. So we have specific social and demographic surveys that we conduct. After that, we do the rapid COVID-19 test or the self-test that is being studied. We assess the usability of such tests, and if they test positive, we can donate more tests so they can take home to test their peers. After that, we do the specific HIV and other STI tests, and the results are shared individually, and they are sent to the different healthcare services depending on the result. If the result from a rapid test is positive for COVID or for any of the co-infections, we collect blood, and this blood will be used inside our lab for our research purposes. The self-test for COVID-19 is the immunoplasma for Diag. So people do their own nasal swab or a swab in the oropharyngeal area. It's a very easy test. When we were first assessing the usability, it was really well accepted without any major issue. And we were able to reach a population that wouldn't look for a COVID test, especially asymptomatic people. Now in the Omicron variant, we have a lot of people that are being infected by COVID and not developing symptoms or very light symptoms. So it's really important to detect these people so they don't transmit the disease in their work environments. Then we have the rapid test for HIV. It's a saliva test. It was mentioned before in the previous presentations. And we have hepatitis B, hepatitis C, and syphilis rapid test. In this case, we use a blood drop to conduct the tests. For the COVID-19 self-test that is being studied together with the James Soor team, we have a specific survey focusing on the usability of the test. So a number of questions that the person needs to answer. And this survey is also included when the person is tested positive and takes more tests home. And then they give us back so we have a general idea on the acceptance of these self-tests. Our target is to get better biomarkers and better therapeutic targets so we can improve patients' response to the severe infections. And so we can also have a trajectory or a pathway to do that in possible future pandemics. Having said that, I would like to thank you for the opportunity. We work in a very large team with people from different institutions. So again, Professor Ana Paula and I, we are the scientific coordinators of this group, and I would like to thank Flavia Pires from James Soor. They have been supporting us with the rapid test for COVID-19 and providing us with logistics support. And here on the slide, you see the long list of collaborators that we have from different institutions. Thank you very much. Thank you, Carlos. Very interesting information about the physiopathology and the immunology aspects of COVID-19. And the plural study to bring the COVID tests closer to people who are also suffering from STIs. We have some questions now. We have a question for Mariana that was sent by Aline Venturini, and she says, we do rapid tests for HIV and syphilis, but we have some difficulties, like getting authorization from the health surveillance service, and there's no standards for notifying the positive results. And she would like to know if this is true for the public service as well. Hi, Aline. Good morning. In the public health system, the HIV and syphilis test is still being studied, so it's not implemented in the public health system. So I cannot answer that question because we don't have that. Daniela will tell you more about the project that we have, but it's still not part of the public health service here in Brazil. So we will get more information on the project, how it's going, but these tests are still not part of our public health system. So we don't have a history. I couldn't give you an answer. I apologize. Thank you, Mariana. Daniela will be part of our next roundtable, so I think she will be able to give us an answer. Alison, do you have a prognosis on the agenda for decentralizing the service to help manufacturers for the different samplings? We follow the WHO guidelines, which talks about the strategies for collecting the samples and how they should be included in the health service, but there are no details in validating the samples. Some manufacturers already do this validation process. We have comparison studies that compare basically a self-sample and the sample that's collected by health professionals, and they assess the performance of one model in comparison to the other. And if the results are satisfactory, these instructions are incorporated in the directions of use, and there's no detail for the validation process. Thank you, Alison. Now we have Ana Paula. Ana Paula, how do you see the future of self-testing for COVID-19, considering the experience that we have with HIV self-testing, and what are the lessons that you learned from the Plural study? Professor Ana Paula? I think I can answer it. Maybe Ana Paula can contribute later. Could you repeat the question, please? Oh, there she is. Hi, could you please repeat the question? Yes. Considering the Plural study, you learned, or do you have some experience with the COVID self-test? And how do you think the COVID self-testing strategy will work in Brazil, considering the experience you have with the HIV self-testing? Certainly, we have great numbers for COVID, and this study is an academic study that is conducted by researchers from the University of São Paulo. And without a doubt, this study can provide us with information and help in the development of strategies to reduce, or better, to have a better diagnosis and to reduce the spreading of the disease. So this is our goal, using self-tests for that purpose, because on our study, we are assessing usability. So we have a survey that will be answered by everyone conducting the self-test. So we identify needs of adjustments. So in the end, we can truly use self-tests to detect the SARS-CoV antigen and as a strategy in public policies to prevent COVID-19 in our country. If I may add something, it's very important. We have this idea behind self-tests and how self-tests can be used in public policies. But when we have a study like ours, we know that the virus, SARS-CoV-2, is not going to disappear. It's in our planet, it's going to stay here. So the best policy is for people to get tested when they are suspicious that they might have it. Especially when we are going back to normal life, people are leaving their houses. So as soon as someone feels anything, gets a symptom, or is exposed, I don't know, maybe in a party or in an event, it's very important for these people to be tested. So I think that in the future, we need to establish this policy, and it should become a part of our routine, so we can have a better quality of life and go back to normal life. Thank you very much to everyone who was with me this morning. Thank you, Mariana from the Ministry of Health. Thank you, Alison, also from the Ministry of Health of Brazil. Ana Paula, thank you for being with us. Thank you, Carlos. Thank you again. Thank you, everyone who has been with us. Now we are going to have another roundtable, and we will talk about self-tests for COVID-19. Because, and let's see if this is a reality or not. We will start in a few minutes.
Vamos a invitar al siguiente.
So, let's invite our next moderator, Mr. Claudio Maierovich from the Fiocruz Institute, and he will be moderating the next roundtable. Carlos, good morning. Good morning, Segundo. Thank you very much to the organizers for the invitation and the opportunity to be here. It's very important when we think about the technology development for diagnosis, and especially right now, when we have a public health emergency, it is important to find new solutions, fast and possible solutions that allows us to move away from this epidemic. The topic of self-tests, without a doubt, is part of the agenda. And I believe that right now, we have two different dimensions. One is what I mentioned before, the fact that this is an emergency. And from what we have learned from the global experience, there have been many advancements, and self-tests have played an important role, not just to detect individual cases, but also to ensure the safety of the different communities and different workplaces or different events that people might attend. Because people with a self-test can protect themselves and protect others. But this is also a trend that was really well presented by the researchers and the professionals from the Ministry of Health, because this is a trend that brings more autonomy to people so they can take better care of their health and get a diagnosis and, of course, start adopting different protective measurements depending on the results. I like to remember that years ago when I was working at Anvisa, before the approval of self-tests and many rapid tests, we had a very strong discussion about the risks associated to self-tests. And we would speculate on different possibilities of how much a pre-test advice would be missed or a post-test advice would be missed, and the risks that could be associated to a positive or a negative result. We have studied that, and here I can say that as far as I know, the team that was working on HIV and STD should be congratulated on the important work that they did, because they were able to transform these new technology advancements into important tools that have been contributing for the control of the diseases.
So I'm the moderator here, and so I would like to invite our speakers, Selena Shokin and Marta Suarez from FIND, to talk about COVID-19 self-testing from the bench to the user room. The floor is yours. There we go. We have the presentation up.
Buenos días y buenas tardes. ¿Me pueden oír bien? Mi nombre es Marta Fernández Suárez y soy la directora de tecnología de FIND.
My name is Marta Suarez. I am the technology director at FIND.
Muchas gracias A Carlos y a los organizadores por invitarnos
Thank
a
you so
participar en este
much,
evento.
Carlos,
Y
and
gracias a toda la
everyone for the
audiencia por cedernos
invitation
su
to
tiempo.
participate in this event.
En esta
And also,
presentación les
thank you
vamos a
for the
explicar la
audience for
posición y
watching
el
us.
trabajo que FINE
In
está
this
haciendo en el
presentation, we
campo de
will
las
talk
autopruebas de
about
COVID.
FINE's work
Terminaremos con una llamada
regarding
a posibles colaboradores para
COVID-19
apoyar las
self-tests.
actividades que estamos planeando en Brasil para
And
el año que
we
viene,
will end
en el
with a
2022.
request for collaboration for the activities that we foresee for 2022.
Pero primero, si me lo permiten, me gustaría introducir brevemente quiénes somos.
First of all, I would like to make a quick introduction about us. So since 2003, FINE, the Global Alliance for Diagnostics, seeks to ensure equitable access to reliable diagnosis around the world. We connect countries and communities, funders, decision makers, healthcare providers, and developers to spur diagnostic innovation and make testing an integral part of sustainable, resilient health systems. FINE was established in 2003 as a product development and delivery partnership, and we are collaborator with the WHO. FINE grew, and we enlarged our mission not only to support the development of new products, but also to increase access to low and middle income countries. Mariana, Alison, Ana Paula, and Carlos made interesting presentations about self-testing for HIV and also self-testing for COVID-19. So I don't have to, talk a little bit more about that. I would just like to emphasize that there were several tests that showed the usability and acceptability of HIV and HCV self-testing. WHO also recommends the HIV self-testing as an additional approach, and HCV as well up from this year. On this slide, I would like to highlight that, like previously mentioned, there are several models so that self-testing can be implemented in a variety of settings. They can distribute it in communities, clinics, pharmacies, or can be sold online. They can also be part of a company's program for employees. It's important to highlight as well that the lack of monitoring after the test is a concern in communities in situations of vulnerability, so we have to support them. We know that models based on performance with self-testing can be supported by a healthcare worker, and that showed an impact in the adoption of self-testing. Also, different types of support can be employed to facilitate the implementation. These instructions can be on paper, by video, or other systems like in person or with direct supervision. Like previously mentioned, there is a highly successful experience with HIV. So I will not be long on this slide. I would just like to explain a couple of successful examples. Moving on to COVID-19. With the pandemic, and at FINE, we believe that self-testing have the possibility to increase the self-test and decrease the burden on the healthcare system. It is clear that this is a strategy that allows traceability and it prevents the transmission as well. There are several studies that shows that the antigen tests are fundamental to break transmission of COVID-19. And the low cost and the rapid results are also important. It's important to highlight that these tests, some of them are very sensitive to detect highly infectious cases. So these antigen tests increase accessibility, free up the capacity from healthcare systems, increase the feasibility of serial testing, help improve containment of positive cases, and foster patient-centered care. Self-testing also gives people the opportunity to test discreetly and conveniently at home. Throughout months, we have seen how much the demand oscillated considering the waves in each country. So it's probable to increase next year if the number of cases increases as well due to the Omicron variant. Moving on now, I would like to show you this chart about the inequality of access of COVID testing. So here you can see the tests conducted by population, by country, and income group. This is a classification by the World Bank, and this number increased from the beginning of the pandemic, but in an unequal way. The blue line is of high-income countries, and our data shows that COVID tests in low and middle-income countries is much lower than in high-income countries. This graph shows similar results.
En este caso estamos mirando la misma métrica.
In this case, we are using the same metric. So it's the number by 100,000 inhabitants, number of tests by 100,000 inhabitants, considering an income group. So here in this line, you have the countries in the Americas. The lower and middle income countries are around 10 and 100 tests by 100,000 people. That's much lower than the high income countries. Considering the charts that I've shown, the goal is to increase self-testing and increase the capacity of countries to conduct self-testing. We believe that this is a very important tool to increase those numbers. It's important to highlight that since the beginning of the year, countries, high-income countries have implemented mass testing. The United States announced a billion purchase of rapid tests and recently announced expansion of their private insurance coverage. High-income countries have also a wide range of implementation approaches in terms of reporting their results, selling tests in pharmacies, supermarkets, online, and delivering at home. There are also examples of self-testing in workplaces, like in the UK, Singapore, in schools, in the United States, and also to serve events like Australia, for example, as they go on to reopen. In contrast, a limited number of low and middle income countries are implementing self-testing in Southeast Asia, India, Thailand, and places like Georgia. In most cases, the access of self-testing is over-the-counter at pharmacies with no government program. Some examples of governmental programs are in Thailand, where there are 8.5 million free self-tests available nationwide. In Malaysia, there are school testing programs, and the self-testing policies are likely to lag 6 months compared to high-income countries. We believe that Brazil and other Latin American countries have an advantage, which is the ability to address its limitations. In this test, we have some questions that we normally pose of the concerns that come up when we talk about self-testing for COVID or other diseases. For example, One of the questions that we hear a lot is, what if we lose track of the cases? A lot of countries show that it's possible to implement digital systems to report the results and prevent authorities to lose the number of cases. There's also a fear of discrimination if the positive results are published. We believe that this fear is valid not only for self-tests, but for all tests in general. People may change their attitude in that sense depending on other factors. And the ability of people to conduct the tests properly. We've heard some opinions of colleagues before us, and there are guidelines that can actually help people to conduct the self-tests properly. So this is our FIND approach. We have identified 3 key components. First, the technology development, working with manufacturers to develop affordable self-testing solutions. Then the policy development, generating evidence and data, and the interventions in the market, understanding demands, ensuring adequate supply. FIND is also planning activities for this year and next year regarding these 3 components. On this graph, you can show the interaction between each area, but regarding technology, we're working with 6 diagnostic partners with their self-testing packages, and we will start the assessment of the performance of tests at the beginning of next year. Regarding policy development, we are conducting various studies to improve the perspective of national stakeholders. We conduct studies regarding values and preferences in 9 countries and studies on feasibility of self-tests. There are also studies on regarding cost-effectiveness modeling. And lastly, we are also planning several pilot programs in various countries, including Brazil. I will touch on that a little bit later. This is another example regarding costs and the volume of production with the companies that we work. The names of the companies are confidential right now. All these prices vary between $1 and $2. The manufacturers have committed to between 10 to 30 million tests per month. Regarding studies on preferences and values, this is a study conducted in 9 countries, among them Brazil and Peru. And this is a study of quantitative and qualitative methods. We study 4 themes in different populations. First, we have the value of COVID-19 self-testing, current testing, accessibility, and preferences of tests. These are some of the preliminary results of Brazil and Peru. We're still analyzing data. This is data collected in São Paulo and in Lima. We can say that in São Paulo, half of the participants responded that they would use a COVID self-test, and the large majority would report positive results to public health system. In Peru, around 80% of respondents would use self-test, and the vast majority would also report positive results to public healthcare systems. FIND is also conducting an online survey with similar questions regarding the self-testing. And countries are presenting similar results as well. But in Brazil, they are a little bit different, and that could indicate that in Brazil, there are more regional differences.
Y por último, estos resultados solo los
In
podemos
São Paulo, the survey has representatives from the whole country, and these are the results for Brazil only. The vast majority would self-isolate after getting positive self-test results. On average, they would be willing to pay 15 reais per test. We will keep on publishing these results because this is a very interesting and valuable tool for countries.
y la estrategia de acceso al
Now, I
software.
would like to invite my colleague, Celina Joaquim, that will share results of the self-testing market assessment and access strategy. I apologize, but I will present in English.
So I'm going to present on a study that we did over the summertime in July and August in 8 different countries to understand the market for COVID self-tests. And this work was done as part of the ACT accelerator work that FIND co-leads for the diagnostics pillar. And as you can see, we studied 3 countries in Asia, 3 in Africa, and 2 in South America, including Brazil. And our purpose was to understand the use cases for self-testing, the segments, and what were the enablers that would increase access and use of self-testing. We also wanted to understand the enablers in each country and to do a model to understand what the market size could look like for self-testing, and then what actions would increase the use of self-testing. Next slide, please. To do this, we conducted over 110 interviews with different stakeholders, and we read a number of different reports and databases. But I also want to stress that this is a very new product. It's in a fluid, nascent market, and things can change very quickly. If there is a new wave of COVID cases, for example, the market could change quite a bit. So these were our estimates based in July. And I will talk through some of the places where there may be some changes since that time. Next slide, please. So first, we wanted to understand use cases where self-testing could play a role. And the green are the use cases we considered, and purple are the ones we did not. So, for example, in work, we looked at large corporations, public sector employees, healthcare workers, micro, small, and medium-sized enterprise employees, and informal workers. We looked at travelers. We looked at different cases in education for primary and secondary schools, both the students and the teachers, as well as tertiary education. We also considered large gatherings, such as a football match, or a church event. We also looked at individuals looking in congregated settings. And then in the health use cases, we looked at exposed and symptomatic individuals. Next slide, please. Then we considered the enablers that would enable the use of self-testing. And the first 2 enablers in any country to allow self-testing is whether the product is authorized, because of course it has to be authorized in order to be available in the country, and the policy. So who can use the test and what are the policies around its use? And those are really the first 2 critical enablers. Once those are available in a country, we then consider supply and procurement, individual accessibility. Can the individual find a test and access it? Funding. Is there funding available? How will the individual pay for it? What is the price? And is it too expensive or is it reasonably priced? Are patients motivated to take the test? Do they know about it and do they want to know their test status? And finally, reporting and monitoring. Is the patient able to report their results? And is there trust in the system from the Ministry of Health and others that patients will report their result? Next slide, please. So what we learned across the 8 countries, and we have a lot of additional information, but just to give you a sense, is that around product authorization, the value proposition of self-testing compared to professional tests is still somewhat unclear and misunderstood, including at the Ministry of Health. And some of that is because the WHO has not yet evaluated the use of self-testing for COVID. And so there's still some confusion, but WHO is now in the process of considering self-testing. We also know that regulatory approval can take a very long time in many countries. On the policy side, there are no normative global guidelines from WHO or others that would guide self-test policy. And policy tends to be very decentralized. We also found that as vaccinations increase, there may be a decreased perceived need for self-testing. And this will be a challenge going forward, is that there's a very strong focus on vaccinations, and some people might not understand we need both. For supply and procurement, many countries have a lack of local supply of high quality tests. And COVID-19 procurement might be very focused on the vaccines, as I mentioned earlier. For individual accessibility, there's often a limited distribution network, especially once you get outside of the larger cities and towns. And sometimes in many countries, self-tests cannot be sold in pharmacies or in shops, which makes them harder for individuals to access. In many countries, the cost of testing could be a barrier, especially in serial testing, which would be in a workplace or in a school. And many countries have limited coverage for insurance or for public sector purchasing. Patient motivation. We found that there continues to be some stigma associated with COVID-19, although that has gone down quite a bit. And in many countries, COVID-19 testing is not perceived as a big need by some segments. In reporting and monitoring, there is limited confidence from the government and from employers that people will take the test properly and report properly. And we found that many reporting systems can be difficult to use, but this varies by country. There are limited systems to monitor and enforce the testing. Next slide, please. So to go into each country, we wanted to first start looking at the current self-testing enablers. And across these 8 countries, at the time of our study, India was the only one where self-tests were currently authorized for use. You can see that the green gives you a positive view of the enabler, yellow is mixed and red is negative. And in India, they have self-tests authorized, but they have limited use cases only for exposed and symptomatic individuals. Supply and procurement is generally not a problem. The tests are available widely online and in pharmacies. Funding can be a challenge, but the cost of self-testing is lower than for PCR and professional antigen RDTs. And there was increasing awareness around getting tested. So this was the only one, but I do want to stress that a number of countries are moving towards self-testing. So beyond India, especially in Asia, we've seen an increase. So Thailand, Cambodia, Malaysia. We understand that the Philippines is very close to authorizing self-testing, and there is also some effort in Indonesia. So particularly in Asia, we see a movement, but at this point, among these 8, it's only India. If we go to the next slide, please. Now, this is a bit busier of a slide, and I'm not going to go through all of it, but what I want to show you is a sense where we're looking mostly for countries that have yellows and greens and fewer of the yellows and reds. So in Asia, India was certainly the most positive environment, because here we would just focus on increasing access beyond the exposed and symptomatic individuals. As I mentioned, the Philippines is very close to approving self-tests, so it's moving in the right direction. And we also understand that Indonesia is considering self-testing as well. In Africa, South Africa was probably the most positive amongst these 3 countries, but they did want to wait for approval from WHO before moving to self-testing, and that could be a few more months before that decision is made. But they would be able in South Africa to procure the tests, and they had multiple channels to distribute them. In Kenya, there was some possibility of moving to self-tests, and they were considering pilots. But in Nigeria, at the time, there was less interest. They also had fewer cases of COVID at the time we did the study. And in Brazil, I will go into more detail in the next slide, but just to compare Brazil to Peru, Brazil is a more favorable environment for self-testing. In Peru, this would require a number of changes in legislation, and we did not find strong political will. And there would be a number of changes needed to be made in distribution channels for individuals to be able to access the tests. Next slide, please. So to go into more detail in Brazil, as you know, self-testing is not currently approved. They would not require in Brazil to wait for WHO for EUL and could potentially consider a US FDA approval. And we know that there is some ongoing discussion about self-testing, but it is not yet, a decision has not yet been made. On the policy side, there is, of course, an increased use of antigen professional testing, but self-testing is not in the national guidelines yet. There is a testing plan, which was launched in September of 21 that does follow WHO guidelines. And we found potential demand for certain niche groups, such as people in remote areas, sales workers, and education. But we did not find it as likely to be used for employers and in higher education because there is already a health professional available on site. And there were some questions about reporting at this time. On supply and procurement, we did not find that this was generally a problem in Brazil, and it was quite favorable. For individual accessibility as well, there were a number of potential channels for pharmacies and public health facilities, and potentially even the postal services in individual accessibility for access to the tests. For funding, the tests would not be covered by insurance, and employers are unlikely to finance the self-tests, but the tests would be likely affordable for the middle class that are already accessing antigen RDTs. On patient motivation and information, there is a new testing campaign that was launched in September. There is some misinformation available, and there is a concern from some health officials that the population might not follow the instructions correctly. And on reporting and monitoring, there is an app that's available for self-reporting, but some questions about how that would be used. Next slide, please. Now I want to move into the modeling to show you how we understood the potential market. So we started with the segment size, which is the total population in the user segment, such as large private corporations, multiplied by accessibility, the percent of the segment who might be able to gain access to self-tests in practice, multiplied by the adoption rate, so the percent of the segment with access to self-tests that might choose to use them, multiplied by the usage rate, so how often they would use the test, if it was once because someone had symptoms, or once per week in a workplace or a school. And that gives us the total use. Next slide. We had 4 different scenarios we modeled. So first is our current use. So that was, if you'll recall, only in India across these 8 countries, and only for exposed and symptomatic individuals. Number 2 is extrapolating our current usage in India to all 8 countries. So the symptomatic and exposed individuals in all 8 countries. Number 3 is our theoretical maximum based on use cases. So in the places where we heard that certain use cases would work, we turned those on or off. And I'll show you this in the next slide. And number 4, we turned on all of the use cases in all of the 8 countries to get our theoretical maximum. Most likely, the true answer is somewhere between scenario 2 and scenario 3. Next slide. So this shows you where we turned on the use case segments. And this was based on the interviews in each country. So you can see that in Brazil, we turned on fewer of the use cases, but we could turn them on and redo the model if needed. But in Brazil, we only turned on private schools, individuals going to leisure activities, and symptomatic and exposed individuals. And next slide, please. And this gives us the volume of self-tests per month for each of the use cases. And so you can see that if we look at scenario 2, that would give us 5 million units per month. And scenario 3 is 60 million units per month across all of the 8 countries. Next slide, please. And this shows you the potential use of self-tests in Brazil. So it's somewhere between 1 and 5 million tests in Brazil. And again, as a reminder, this was done in July, but we think this is fairly accurate. Next slide, please. So here we considered what are the most important policy actions that we could undertake in order to increase access to testing. And starting in India, which was one archetype, we would focus on policy, so expanding beyond the exposed and symptomatic individuals, as well as addressing funding issues. If we look at Brazil, as well as the other countries that were somewhat similar to Brazil in this study, these were countries with higher GDP, higher access to health coverage. Here in these countries, we would focus on product authorization, so getting the product approved in the country, and policy. And this really had the highest potential of self-test users, which was around 1.5% to 3% of the total population. And the best use cases that we found in these countries were the large private corporations and the public sector employees. And then finally, our third archetype, which was the countries in Africa, Nigeria and Kenya. And here was more of a challenge because we had to focus on 4 of the different enablers. And honestly, the upside was a bit lower. There were limited use cases and smaller potential. Next slide, please. And this is just to give you a sense of the different actions that we identified that could be taken to address each of these enablers. And I know this is quite a lot in one slide, but give you a sense of which activities, which ones are colored, are already underway or being planned. So for example, working with manufacturers to seek WHO EUL or stringent regulatory authority approval, identifying local stakeholders to navigate the authorization process, supporting WHO to develop normative guidelines, launching trials, as well as establishing exchange and learning mechanisms. So really there are a number of different activities that could be taken to increase access and to address each of these enablers. So I think I will stop there and hand back to Marta. Thank you very much.
Muchísimas gracias, Celina, por tu presentación. Para terminar, solo nos gustaría hablarles de uno de los proyectos.
Thank you, Celina, for your presentation. To conclude, I would like to talk about some projects that we think about doing in Brazil and other countries. The main goals are to optimize self-testing package for 2 or more priority user segments, for example, schools and workplaces. Second, generate evidence to support national policy development. And the third, a pilot implementation in specific user segments. We are thinking about different activities. The first one is the number of workshops and interviews with national enablers, so that we guarantee that we are prioritizing the user segments properly. The second is a survey with target user segments before implementation of the pilot programs, so that we all have everything aligned at the beginning of the project. We also want to implement the pilot programs at the second half of the year. And this would be the end of our presentation. Thank you so much. And if you would be interested in participating or collaborating with our workshops that we are planning for the beginning of next year, get in touch with us. This is our contact email. We look forward to that. Thank you so much again.
Muito obrigado, Marta,
Thank you so
Celina.
much, Marta and Selena, for such an incredible presentation with such important information. And now I would like to hand over to Mohamed.
Good afternoon, good morning, good evening to everyone on the call today. I would like to thank everyone for allowing me to come and present. I will be speaking in English because my Spanish is not very good. And I hope everything is clear enough. So without further, can I continue? Is everything okay? Can I go ahead?
Yeah.
Audio?
Yes.
All right.
Go ahead.
Thank you. So today I've been asked to present on the usability of COVID self-testing, and I want to really involve with the self-testing program in South Africa and globally over the last 6 or 7 years, specifically in terms of evaluation of candidate products for self-testing purposes. So the talk today is more around my experience from the WHO pre-qualification processes. It's a bit of a step back from the great talk that was just provided now by the fine team. So in terms of my presentation today, I'll be looking at the lessons learned from the pre-qualification of HIV self-testing and some of its applications for COVID-19 self-testing. If we go back to simplicity and go back to the basic, what makes a product profile for HIV self-testing that was developed in 2014, which gave us an indication of what we were looking at to get from a good test. We wanted a test which had high clinical and analytical sensitivity and specificity, a test that will give us low invalid or failure rates, instructions for use which had more pictures than words, and that was translated into local languages. We wanted as minimum steps as results which are simple enough to interpret, a reduction in time to result, and stability of test results. And I think these principles stand through for all self-tests, whether it be HIV, hepatitis C, COVID, and these are some of the technologies that I've been involved in over the last few years. So I think going back to 2015, and when I started on this journey of evaluation of products, self-testing that existed at that point were numerous. But one of the main ones that existed was that there were no requirements from the WHO in terms of pre-qualifications for self-testing, and these were not defined. We're in a very similar space now with COVID self-testing as well. And I think a lot of the lessons that we have learned over the last 6 or 7 years on the HIV self-testing journey these lessons can be brought forward for us because we are now in a very similar space. So in the absence of having a framework from which to work upon for WHO purposes, and we work very closely with the pre-qualification team, Robin Muren and Irina Pratt and Anita Sands at the time, whilst they were developing the technical specification series for an evaluation framework, which we thought may be relevant and may be useful for HIV. Just going to turn off my video. one that went from non-clinical studies to looking at usability assessments, to trained user assessments, intended use, expected use cases. And again, we are talking a very similar situation now with COVID. So in 2015, we kicked off a program whereby, and this was prior to WHO pre-qualification guidelines, kicking off the program that looked to evaluate candidate HIV self-tests, utilizing that framework of taking products through the various stages of evaluation. Later that year, the pre-qualification team came up with a technical specification series, and it was very important that our protocols matched the requirements of the TSS. So if we look at the main requirements of the TSS, and now this goes for hepatitis C self-testing as well, and we think it will be something very similar for COVID self-testing as well. We took the product through two protocols, essentially. The first one being a usability assessment, where we wanted to understand how well could the test be used in the hands of untrained users. And with the various parameters that we looked at were label comprehension, mock result interpretation, and the overall product usability and failure modes. It was important that no demonstration or training was provided to the end users prior to the evaluation taking place. Once a product was deemed to have a high usability, we then took it to the next stage of evaluation, where we compared it to a gold standard. And for the case of HIV, we compared the performance of the self-test to the rapid test on the algorithm, national algorithm, and to an ELISA, fourth generation ELISA test as well. So over the course of the last few years, we've evaluated numerous products in the hands of untrained users, where we provide them with nothing but the test kit and the instructions for use, and ask them to go about conducting the test to ensure that we can determine whether the test is usable in the majority of the population. For this purposes, we looked at differing education levels, literacy rates, age, gender, ethnicity, so we could get a good mix of the South African population to understand whether those individuals with a low education level are still able to do the test, and how does it compare to higher education level. So we're quite experienced in this space. For HIV, we've evaluated over 8 or 9 different products in the course of the last few years, and quite a few of these have either got WHO pre-qualification or in the pipeline. Similarly, we've done quite a bit of work for hepatitis C self-testing in partnership with FIND, and now looking at doing something very similar for COVID self-testing. So we've learned the lessons for this. Of the products that we've evaluated, we have 4 products that have pre-qualification, and all 4 products were evaluated in our facility on the same standardized protocol. Through our relationships and partnerships with PATH and FIND and others, we've been able to set up a network of relationships of sites across the globe that conducts various assessments on similar or the same protocols, depending on the requirements from a prevalence perspective or strain perspective, as in the case of HIV-2 in West Africa. But we could look at high and low prevalence for the various disease states. And we've set up this network of partners where we can run similar interventions across multiple countries. So just going back to an example of the usability assessment and what do we actually track and how do we go about tracking it, the participants provided a test kit and an instruction for use, no demonstration. An observer who's a professional nurse would sit back and record the specific steps of how the person conducts the test. And then we score the performance of the test according to the successful completion of each of the steps, calculating a usability percentage based on the average of all of the different steps, and then also highlighting which are considered to be the critical steps. What it allows us to do in this process is to go into those or hone into the steps which are problematic. So for example, in this example that I've provided, in step number 7, we saw that there's only a 68% completion rate on that specific step. We can then address that step with the manufacturer to tell them that this probably needs to improve if you are to improve your usability of the test. A lot of the data that we've looked at has been published, and I've just wanted to pull out an extraction from one of the tables where we could do a comparison of multiple self-tests across the same protocol with 900 participants across each, to show that we can measure and then compare products according to a single standard, utilizing a standardized protocol which allows this cross-comparability of the device performance. We also serve as an independent evaluator for WHO and not necessarily a WHO pre-qualification site. Like I said, in terms of recommendations for the further development of the tests, once the evaluations are completed, we can go back to the manufacturers and show them where people have made mistakes on the evaluations and how some of this can be fixed. Some of it is minor fixes. For example, in the picture that's shown, we've shown that just alignment of the picture to the actual buffer pot stand made a huge difference to the usability, because now individuals were not placing the buffer pot on the table and rather placing it in the stand as provided. So these subtle changes can improve usability, and it's something that we've done for numerous tests now to improve their performance. So to answer the question on COVID-19 self-testing, and based on my experience with HIV and hepatitis, do I believe it's a reality? I certainly believe so. However, the pathway which took us from the point of company-initiated R&D products to having a policy, and again, sorry for just citing a South African example, I work very closely with the South African program, but to move from the point of having a R&D product to government policy took a period of 4 to 5 years. And we know that with COVID, we don't have that 4 to 5 years. This took the products, at each step, the products had to be researched, they had to be evaluated. There were implementation use cases that needed to be evaluated. There was guidance that was needed to be put in place. And like I said, all of this took a period of 4 to 5 years. With COVID self-testing, we don't have years, we have months. And we've as a global society, have to condense this process into a much shorter time period. And this requires, with the unprecedented speed of development, it requires a lot of parallel processes to ensure that we reach the markets that are needed quite quickly. And I think that an important point is that it requires political will. Having been involved with the National Department of Health and the regulator in South Africa, I can see now how difficult it is from a single country perspective for manufacturers, for products, for donors to get approval of COVID self-testing in one setting. I can only imagine what that is from a global perspective for multiple countries wanting evaluation data. So I think we are all pushing towards the same goal. However, we have these parallel processes that are taking place. And I'm happy to see that my thinking is aligned to the previous presentation from the FINE team. So we've been involved in various processes and things that need to take place at the same time. We know that WHO are in the process of determining guidance on self-testing, and the WHO pre-qualification team looking at the requirements for the technical specification of these products. I think it will be good to have a set of pre-qualified products so that countries don't have to do country by country assessments of these products. The regulatory requirements for each country needs to be determined, and I think in the absence of global guidance, leaving it from country to country is going to make it very challenging. The development of policies and guidelines for usage of these test kits needs to happen concurrently, but that can only happen if we know what use cases we're looking at. And as identified in the last presentation, there is very little implementation taking place in low and middle income settings, and much of the usage of both professional use antigen testing and self-testing has been in higher income countries. And we know that the use cases that are utilized in higher income countries cannot necessarily translate to lower middle income countries, especially with the usage of digital tools. There is a learning curve. However, I do believe that In a country like South Africa, we certainly would welcome the usage of COVID self-testing. And I think I can speak for much of sub-Saharan Africa, where HIV self-testing has been something that's quite commonly used, with over 6 million tests being distributed over the last few years. There isn't a sort of inherent knowledge of self-testing that already prevails in the market. There's various market shaping interventions that we've seen from the FINE team as well, which will be hugely beneficial, especially when it comes to a cost perspective and a volumes perspective for lower middle income countries. As we saw with the vaccine inequity, the lower middle income countries have been left behind. So in terms of us establishing usability amongst end users, there are certain things that I think we need to consider, and this is just based on some of the other products that are some of the other evaluations that I've completed. Self-swabbing is not the same as a blood finger prick, and difficulty in a lay user determining adequacy of a sample. So has the participant or the individual swab their nasal passage well enough, high enough, long enough to get an adequate sample? How would they know? And how would they be able to determine whether the sample they've produced is adequate, and we're not seeing a negative result on the basis of it being an inadequate sample? It really comes down to the actual product that we're looking at and how easy it is to actually complete the test. Timing of the test, and how do we convey the message of when is the best time to use a self-test in terms of symptoms and in terms of contact with a positive, that window of sort of antigen, the best performance of an antigen test between 3 and 5 days post-contact. How do we communicate that to the end user? There are a lot of interventions around test and treat, which are starting to take up, and how can we utilize the self-test for these interventions? Are we still going to rely on somebody getting a second test, a PCR test, a confirmatory PCR test, and losing very valuable window time? Or can we rely on the result of a self-test for test and treat interventions? And I think usability and result interpretation in low middle income countries is always going to be important, where we do have lower literacy levels, especially within rural settings. So these are some of the things that we need to consider when evaluating products and when thinking of which products are more suitable for which market. So we're part of a program working very closely with the FINE team in terms of evaluating usability and performance of candidate tests, which we're hoping we'll be able to start by June 22. The protocol has been developed in consultation with WHO to ensure possible future alignment with the technical specification series. So we're hoping to get really stuck into these evaluations and take out the learnings from what we're seeing, so that we can utilize it for the global market, similar to what we've done for the HIV program. Thank you. That's my presentation for today, and I'll be happy to take any questions.
Muito obrigado, Mohamed, pela interessantíssima.
Thank you, Mohamed, for your very interesting presentation. We have a few minutes left, and first I have a question for Selena and Martha from FINE. They have presented a very interesting material, but how do you see the experience from different countries that are already using a self-test, especially European countries, how they are using self-tests to control COVID-19? Martha, Selena?
I can start, Selena, you can chime in as needed.
Eu posso começar.
So we see different experiences in the high-income countries, and I would say the experiences have changed over time as well.
And these experiences have changed over time.
Studies that were done on some of the initial implementations were perhaps not completely embedded in a system that provided a structure and provided enough instructions and support to the individuals. I would say that has evolved over time, and programs are now being a lot more effective. In many of the high-income countries, still the majority of the programs are based on pharmacy and online retailing. Some of the countries are also including requirements for reporting that are allowing the participants to report the results. So I would say there is a lot of room for improvements. Some are more advanced, some are less, and some countries have to scale up to the whole population, like UK or Singapore, whereas others are focusing more on specific segments, like being in a school testing or in the workplace. It's very important that each program is really tailored to the country and the reality of that country. And it really depends both on the healthcare system as well as the school system or how the workplaces are implemented. So that's why, for example, in the pilots that we're going to be conducting in these 3 different countries that we have decided to focus, we are going to be focusing on specific segments and designing those pilots to be very tailored.
Thank you. Selena, do you want to add something?
I apologize because I did not understand the question in Portuguese. Can you summarize it?
Yes, I was asking you, how do you see European and many countries, usually high-income countries, have the experiences with self-testing?
Well, as Martha said, I think the higher income countries have a varying amount of experience, and the European countries are doing really quite well in getting out the self-tests. It's been a bit more of a mixed experience in the United States, for example. What we're trying to do is to show examples of countries, even in low and middle income countries, that are doing a good job with self-testing, such as Malaysia and Thailand and Cambodia, and to share those experiences more broadly, because we think this self-testing should be an option for all countries and not only the high income countries.
Thank you, Selena. And now I'll bring a question to Mohamed also. Mohamed, in this pandemic, we've been seeing WHO make recommendations like treatments and testing, diagnosis. It was not usual. Do you believe WHO will take a position about self-testing, maybe going beyond the technical approval and making recommendations for using a NOTIS in different kinds of countries?
Yes, absolutely. I don't see why and how they should not do so. Depending, it really comes down to timing and having enough evidence to suggest that they can be making a recommendation on the usage of self-testing. So I think as evidence gets generated, WHO will definitely come to the party with guidance for countries. I don't think at this point we have sufficient, but like I said, so many things are happening in parallel. We first need good products before we can get to the stage of implementing and testing out these products from global perspective. But I do think by end of Q2 next year, there should be at least some sort of indication from WHO on the usage of the tests.
Thank you. Bom, obrigado, Selena, Marta, Mohamed.
Thank you, Selena, Martha, Mohamed. This was a very interesting panel, and we will be talking about it in a while once we have a larger use of these technologies, because this is a very moment that we are defining basis, technical basis, legal basis, political basis for interesting and important changes. Thank you so much. Thank you, Carlos, again for having us and for inviting me to moderate this panel. Claudia, it was an honor to have you brilliantly moderating this discussion. Martha, Selena, and Mohamed, thank you so much. It was a very interesting presentation about your experiences and about the future projects, and that will help us a lot in our region. So thank you again.